And now it's a pleasure for us to introduce the speaker for the session, Professor Azoulay. He's well known, he's professor of HPB and liver transplant surgery. He has a special interest in complex liver surgery, in extreme liver surgery, and of course, in liver transplantation. And he has a well-known bibliography with a lot of research, more than 450 index papers. So if Professor Azoulay, if you are ready to start with your talk, it will be a pleasure for us to listen to you.
Yes, I am ready. If you can launch my first slide, please. We had a small issue today, so I will not control the slides, and I will ask Carol to go to the next slide. So thank you first for this invitation. I'm very sad not to be in Bilbao physically, because I was told that the food is very good in Bilbao. So I miss this in this virtual meeting, but next time I will be there. So thank you again for this invitation. My topic is about complex portal vein thrombosis, the management of this thrombosis in liver transplantation. I've been working to prepare this talk with my colleague from Medanta in India, Prashant, and my colleague from Spain, Alejandro Serrabio. Can I go to the next slide, please? So I want to start with a few facts. This is very old slide. You see, it's a very old paper, more than 30, almost 40 years old. And it was very clear, if you can go to the next slide, that already, if there is no portal flow at liver transplantation, there is no survival possible, either of the graft and also of the patient. So this is a fact that is known since the beginning of liver transplantation. Next slide, please. Another fact is the impact of portal vein thrombosis on the results of liver transplantation. You have this paper from Gabriel in 2016 about thousands of liver transplantation. Next slide, please. The first point is that, as you can see, only 30% of patients with portal vein thrombosis at the time of liver transplantation had in fact portal vein thrombosis that was reported at listing. So to discover a portal vein thrombosis during liver transplantation is not a rare event, at least in the United States. The second fact is that if you look at the survival, the patient survival and the graft survival, comparing patients with and without portal vein thrombosis, you see that patients with portal vein thrombosis have a lower patients and graft survival. And this, next slide, this significant difference then appears, next slide, the next, yes, you see the difference, in fact, appears during the first 3 months of liver transplantation. After these 3 months, the curves are parallel. So the impact of portal vein thrombosis on the patients and graft survival takes place, in fact, during the first 3 months following liver transplantation. And this is probably related to the remaining portal hypertension. I will come back on this point. Next slide. The problem of this type of study is that they never clarify whether the patients with portal vein thrombosis had complex or non-complex portal vein thrombosis. Next slide. This is another study 7 years ago. Next slide. It's a systematic review showing that patients with and without portal vein thrombosis after the year 2000 had comparable survival in terms of 1 year survival. So after 2000, obviously, we have progress. Next slide. But again, it was not possible to clarify in this systematic review the complex or non-complex type of portal vein thrombosis. Next slide. Third example, another systematic review, almost 100,000 liver transplantation. You can see that in this study, portal vein thrombosis was present in about 7% of patients. Next slide. Again, portal vein thrombosis was a risk factor for 30-day mortality. You see that with patients with portal vein thrombosis had a 13% thrombosis, almost the double at 30 days as compared to patients without portal vein thrombosis. Next slide, please. No, next. At 1 year, again, there is a difference in terms of mortality in patients with portal vein thrombosis. Next slide. Okay, it's a risk factor of a 1 year survival. Next slide. And if we compare, in this series, they compared partial versus complete portal vein thrombosis. Again, the 30-day mortality and the 1 year mortality was higher in patients with complete, not complex, complete portal vein thrombosis. Next slide. Okay, next. This is a way to, I'm sorry, I don't have the animation. Sorry, bye. Next slide. Again, in this series, impossible to clarify the type of portal vein thrombosis, whether it was complex or whether it was a simple portal vein thrombosis. Next slide. So this slide shows that there are at least 2, 4, 6, 8, 9 classifications of portal vein thrombosis. No one of these classifications has a common type. There is no one common point in all these 9 classifications. And if you look, next slide, if you look at the impact in terms of surgical decisiveness, whether the classification help us to decide the surgical management of portal vein thrombosis. Next slide. You see that we have only 3 classifications out of 9 that have some impact on the decision that we will take during the operation, because this is the problem. The question, the issue is to have a classification that could help us to manage the portal vein thrombosis during the procedure. So, of course, you have the Yerdell classification. I will come back on this one. And the Jamison and Charcot classification, in fact, are very similar. So, finally, we have 2 classifications with some surgical decisiveness. Next slide. So, this is the classification of Yerdell, the most known classification. It is now more than 20 years old. It was described by this young surgeon Yerdell, but in fact it was under the guidance of Jacques Pirenne. I think it's important to recall his participation to this classification. So you have the stage 1 portal vein thrombosis, partial portal vein thrombosis, less than 50%. Stage 2, total portal vein thrombosis, but the splenic vein and the mesenteric vein are patent. Stage 3, the superior mesenteric vein is obstructed, but the proximal part of the vein is still patent. And stage 4, next slide, this is the type. Next slide, please. Hello? Yes, this, the stage 4 is the most severe, the most complex portal vein thrombosis in this classification. But please note, there are 2 issues with this classification, this stage 4. First, we don't know the status of the very proximal branches, tributaries of the superior mesenteric vein. And more importantly, we don't know, in this stage 4, it's not clarified if we have or not portosystemic shunts that can be surgical or spontaneous. Next slide. So this is the first point. The third point, this is the 2 points. The third point is to clarify with you what is physiological and non-physiological portal reconstruction. EB and colleagues in 2014 defined the portal vein flow reconstruction as non-physiological when the portal vein flow to the graft could not be reinstituted. This was the definition until 2014 of non-physiological or physiological reconstruction. Next slide. In fact, I think, and we think with some colleagues, that this classification is rather anatomical versus non-anatomical. It's rather than physiological, in fact. It's more anatomical, whether we can reconstruct the portal vein or not. Next slide. So we propose, in fact, to change this classification and to consider that the portal flow reconstruction is physiological when somehow, one way or another, the portal flow can be redirected to the liver graft. Next slide. So if we can redirect the portal flow to the liver graft one way or another, via the portal vein or via a shunt, and we will come back to this, this is a portal physiological reconstruction, because as the portal flow one way or another is redirected to the liver, this should solve the portal hypertension, because this is the issue of liver transplantation in patients with portal vein thrombosis. Next slide. So for stage 1 and stage 2, you know, it's quite easy to disobstruct. You have here an example of a large thrombosis with eversion of the portal vein. In these two stages, 1 and 2, it is quite easy to disobstruct this portal vein and to have a good portal flow. Next slide. Next slide. So with this, in these patients, there is a portal thrombosis that can go low in the portal vein, but there is no diffuse portal vein thrombosis. The disobstruction is easy, the reconstruction is easy, and the portal flow is physiological. The reconstruction is physiological because the portal flow will go through the liver. Next slide. Yes. For the stage 3, thrombosis of the portal vein down to the superior mesenteric vein, it is possible, you know, and this is now since the 90s, to jump the SMV to the graft portal vein. Next slide. And you can see in blue the jump venous graft from the SMV to the graft portal vein. And next slide. This is non-diffuse portal vein thrombosis. It is relatively easy reconstruction, and the portal flow is physiological after this reconstruction. So for stage 1, 2, and 3, it's quite easy to reconstruct the portal flow and to have a physiological reconstruction. Next slide. Now, the problem is with the diffuse portal vein thrombosis, stage 4, but going very low in the system, in the proximal portal system. And in this type of diffuse portal vein thrombosis, the question is, do we have a patent shunt between the portal system and the systemic system, or do we not have this patent shunt? And we will see now these two situations. So now with patients with portal vein thrombosis with the patent shunt. Next slide. Next slide. I will do the animation on one side because otherwise it's difficult. Yes. So the first type of shunt and the most frequent is the splenorenal shunt or the gastrosplenorenal shunt between the spleen and the left renal vein. In this situation, with a diffuse portal vein thrombosis and a large splenorenal shunt, it is possible to jump from the left renal vein to the portal graft vein and to redirect the portal flow from this shunt to the liver graft. Next slide. You have here in the middle the left renal vein that will be jumped to the graft with the interposed venous graft, and you have the schematization of the flow at the end of a renal-portal anastomosis, left renal to portal graft anastomosis. Next slide. In this situation, the reconstruction is physiological because the portal flow will go through via the left renal vein to the liver graft, and we have a physiological reconstruction. Next slide. This is just to illustrate on the right side the control of the left renal vein that will be used for this renal-portal anastomosis. Next slide. Again, another illustration we reported 21 years ago. Next slide. You have the splenorenal shunt on the left side and the flow going to the graft via the renal portal anastomosis. Again, it's physiological and it solves the portal hypertension. Next slide. It's physiological. Next slide. So we reviewed this renal portal anastomosis 10 years ago, and you can see down that the mortality of this renal portal anastomosis was 1/4, almost 25% of patients died after this type of reconstruction, and the patient survivors was 76%. This was 10 years ago. Next slide. If we update this review of the literature to 2021, you see that, next slide, the mortality is a little bit lower now, 17% for this experience in the literature. Next slide. And the survival is the same, in fact. It's 74% in the long run. Next slide. So we did not progress that much with this renal portal anastomosis since the beginning of this procedure. Next slide. Now, the second type of spontaneous shunt is the large gastric vein, left gastric vein, in the case of a diffuse portal vein thrombosis. It is possible in these cases to jump this left gastric vein to the graft portal vein and to, again, redirect the portal flow to the graft. Next slide. You have here an example of the large varices on the upper part of the slide, the large perigastric, periesophageal varices. Next slide. And next slide. And you have, again, in this situation, when we use the left gastric vein, in a case of diffuse portal vein thrombosis, again, the reconstruction is physiological. Next slide. Okay, this is another example. The portal vein is very small diameter. It was not usable. Next slide. Next slide. Yes, so this is a reconstruction with the left gastric vein that was stapled. So if we look at the use of this left gastric vein to the graft portal vein anastomosis, you see the number of cases is very small. Next slide. Very often, the grade of portal vein thrombosis is not available in these reports. Next slide. And you see that finally, if we have about 40 cases reported in a very long period, the postoperative mortality was 0, but we have to be very cautious about this because most of these studies are case reports or small series, and all surgeons, we have tendency to report only successes. We don't report our failures. So this is why probably the mortality is 0. The postoperative morbidity was impossible to clarify in this review, and the long-term outcome was available in 21 cases, and 19 of these 21 cases were reported as alive with a good portal vein reconstruction. Next slide. Now, more difficult after the renal portal anastomosis and the gastroportal anastomosis is the use of a pericholedochal varice. In these cases, I took it from the literature. It was published in 2014. In some cases of diffuse portal vein thrombosis, we can find in the portal triad a large pericholedochal varice that we can use to reconstruct the portal vein. Next slide. Yes, this is a schematization of the situation in the cirrhotic patient with diffuse portal vein thrombosis and a large pericholedochal varice. Next slide. And this is a reconstruction to schematize, to show the reconstruction. Of course, in these cases, using a pericholedochal varices, it is safer to do a Roux-en-Y to reconstruct the bile duct because there is these large varices around the native choledochus. Next slide. So again, in this case of using a pericholedochal varice, it is difficult, but it is feasible. the reconstruction is physiological because the portal flow, again, will flow through the liver. Next slide. Very few cases, you see. Next slide. 11 cases were reported until 2017. No mortality in the postoperative course. Impossible to clarify the morbidity and specifically the morbidity related to the reconstruction. But the long-term results were available in 11 cases, and 9 out of 10 had a patent reconstruction at the last follow-up in the papers. Next slide. Yes. Of course, there are other situations where we can use a large varus or another tributary of the portal system in case of diffuse portal vein thrombosis. We can use the right superior colic vein, the ileocolic vein, and many veins. And these are, again, they are physiological when we can use these veins. Next slide. Now, more difficult, diffuse portal vein thrombosis and no shunt, no surgical shunt, no spontaneous shunt. Next slide. In this situation, in some centers, next slide, in case of portal vein thrombosis that was complete with no systemic shunt, these centers, they consider this situation as a contraindication for liver transplantation. It's a little bit funny because this paper comes from my center. And I disagreed, and I'm not co-author of this paper. I disagreed with this paper because I think in this situation, there are still some solutions to try to counter this situation of diffuse portal vein thrombosis and no systemic shunt. Next slide. First of all, there are some tricky cases that we can, if there is no shunt, we can create the shunt. In this case, in a patient with a large part of the splenic vein that was patent, we performed a splenorenal shunt and then a renoportal shunt. Next slide. Yes, next slide. Next slide. Here. You have here the reconstruction that we did in this patient who had diffuse portal vein thrombosis, but only a part of the splenic vein was patent. We performed the splenorenal shunt on the right side of the slide with an interposed PTFE graft, and then a renoportal shunt. So there was no shunt, and we created the shunt. But this situation is rare, but I want you to know that it is possible. Next slide. Yes, this is the flow. Next slide. Okay, our construction is physiological because we created a shunt during the procedure of liver transplantation to make sure that the portal flow will go back to the liver. Next slide. Yes. Now, the second way to solve the problem of diffuse portal vein thrombosis without shunt is to do what we call a hemi transposition, cavo-portal transposition. This operation was described by Tsakis in 1998, but we already performed some cases before and we reported our experience in 2000. Next slide. Next slide. Next. Okay, so we have three types of hemi transposition, either a cavo-portal anastomosis without any management of the retrohepatic IVC. The second situation is to squeeze a little bit the retrohepatic vena cava to favor the flow to the liver. And the third situation is to interrupt the retrohepatic vena cava. These type of situations are different, and it is not yet clear which is the better. However, probably the better is in the middle, when we squeeze the retrohepatic vena cava. Next slide. So this was in 2014, a review of hemi transposition. Next slide. You see that out of 103 cases, next slide, Varicose bleeding after the operation was very frequent. 1 patient out of 5 would bleed, with of course, remaining portal hypertension after the operation. Thrombosis was frequent, 15%. Severe renal failure was frequent. Next slide. And more importantly, mortality was very high, 35% after this type of operation. Of course, you have to balance with the risk of non-transplantation in this patient, and you have also to balance with the graft shortage that is still worsening for every one of us. Like, next slide. The last possibility is to arterialize the portal vein in case of absolutely diffuse portal vein thrombosis, and we cannot use any branch of the portal system. It's really a last resort. There are very few cases, 9 cases for primary portal vein thrombosis and 5 for secondary portal thrombosis. It's a salvage solution. There is a risk in the long term of fibrosis of the liver and aneurysm of the portal vein, and everybody will agree that it is really a last resort. Before this last resort, next slide. Well, this is an illustration of portal vein arterialization between the aorta, below the renal arteries, and the portal vein. It's a case we performed a few years ago. The patient had a good survival, but developed ascites. Next slide. Now, this is, in fact, the real solution. At least theoretically, the real solution is to bring the portal vein and the portal system together with the liver graft to the patient with a diffuse portal vein thrombosis without any shunt. This is the only procedure that completely reverses the portal hypertension and treats the disease of the patient. However, this type of operation needs, by definition, evisceration of the patient. You have to remove the liver, the stomach, the pancreatico-duodenal complex, the spleen, the small intestine, part of the large intestine, and you preserve only the vena cava and part of the colon. This operation was proposed by the group of Indianapolis, by Viana, to treat patients with diffuse portal vein thrombosis. Next slide. They reported very good results. As you can see, the patient and graft survival was 72% at 5 years, which was 5 years, which was a good result. Next slide. Yes. Next slide. Voilà. Next. If you compare now the patients that we reported in 2011 with the hemi transposition to the patients from Vienna, from Indianapolis, who had a multivisceral transplantation for the same type of disease, we could compare these 17 of their patients to 20 of our patients. You see, the mortality was comparable. Next slide. The morbidity was not that different. It was even lower in our group. Next slide. And the 5-year survival was absolutely the same after 5 years. So I am not absolutely convinced that by this operation, and I must say that these results were never reproduced by any other team so far. So I think it's interesting. Probably there is a place for this operation, but there is a note of caution that we should keep for this operation. Next slide. Next, yes. So now I want to propose you another classification of complex portal vein thrombosis. And I propose to you to consider the complex portal vein thrombosis, the patient with the Yerdel-4 or the patient with Jamieson and Charcot 3 and 4, and to group all these patients into a group of complex portal vein thrombosis, and to define the reconstruction as physiological, provided the portal flow, one way or another, goes back to the liver. And with this proposition, we could end up, next slide, we could end up with an algorithm. Next slide. The first thing is to prevent, of course, the progression of a portal vein thrombosis when it appears during the screening by anticoagulation. And if there is a failure of this prevention, we end up to complex or non-complex portal vein thrombosis. When the portal vein thrombosis is complex, next slide, the first question is there a shunt? Is there a shunt, surgical or spontaneous, that we could use, next slide, during the procedure? This is the question. So this is the analysis of the imaging of the patient before transplantation. And this important point to repeat the imaging during the waiting period to make sure that this shunt is not disappear. Next slide. If it is present, if there is a shunt, surgical or spontaneous, at that time, we can do a splenorenal shunt, gastrorenal shunt, any operation that will redirect the portal flow to the graft. And of course, all these reconstruction, when there is a shunt, are physiological. So we have a complex portal vein thrombosis with a large shunt that we can use to do a physiological reconstruction of the portal system. Next slide. If the shunt is absent, at that time, the problems are beginning. And for our group, in order of preference, we do a renoportal anastomosis, even if there is no shunt. And we could discuss this later if you want. We do a cavoportal anastomosis, second option. Third option, probably I would prefer for calibrated portal vein arterialization rather than multivisceral transplant. I am not still convinced by this operation. All these, except multivisceral, are non-physiological and are, of course, hampered by the postoperative portal hypertension. Next slide. Next. Okay, a few words about the tips in portal vein thrombosis. You see this no, you are going too quick. Go backward. Backward. Yes, the tips in the case of portal vein thrombosis. Tips, no, next. Yes, the tips to prepare the patients for liver transplantation in case of portal vein thrombosis was proposed by the group of Salem already 7 years ago. But if you look at this series, there were 61 patients, but there was no one stage 4. So we cannot use these tips to prepare a patient with a diffuse portal vein thrombosis to prepare him to transplant. And to my knowledge, so far, there is no one case of tips in the collateral that could be used in liver transplant. Next slide. Yes. Yes, next slide. These are the complications, not interesting. Next slide. Yes, the more recent series of tips in patients, no, you are going too quick. Backward, please. One slide back. One slide. Yes. The last series of the use of tips in patients. No. Next. Yes. Next slide. Next. Yes. The last series of tips in the management. Non, mais c'est pas vrai. Come back, please. Yes. Can you stop? Thank you. So this is the last series of tips for diffuse for portal vein thrombosis. You see that this series of tips in patients with portal vein thrombosis, almost 300 cases. There was only one case of liver transplantation following tips in a patient with portal vein thrombosis, 0.4%, and the grade of the portal vein thrombosis in the case of transplantation was not clarified. I wrote an email a few days ago to the first author. I am waiting for the answer. So this is what we should obviate when we use the tips, of course, to put it too high in the right atrium. So you have to open the pericardium to get the prosthesis back. Next slide. Next slide. Well, this is only a complication of tips. Next. Next. So the message for me is that the portal vein, no, come back, please. Take home message. The portal vein thrombosis develops in about 11% of patients with cirrhosis and end-stage liver disease, and the detection is very late and very often during the transplant. The presence of this portal vein thrombosis has an impact on the post-operative outcome. The diffuse portal vein thrombosis remains a contraindication for many series in many centers, and it's a major challenge, technical challenge. Next slide. Next slide. So I think you have understood this message. I will go to my conclusion. So my conclusion is that portal vein thrombosis was for a long time a contraindication to liver transplantation. Now we have many strategies in case of portal vein thrombosis to solve the problem and to reach a physiological reconstruction. If the reconstruction cannot be physiological, at that time, we have to decide on a case-by-case basis. Thank you very much for your attention.
Thank you very much, Professor Azoulay. This was an amazing lecture. Can you hear me well?
Yes, I hear you.
Yes. So we are going to start with the question. We have one question.
Yes.
From Laura.
Hello, Laura.
Hello, professor. ¿Cómo
ça va? Ça va bien. Tell me.
Bueno, first of all, thank you for the great presentation as always, but I would like to pose two questions, practical questions. First of all, if in the challenge case of diffuse portal thrombosis without shunt, you would prefer to create this shunt as you have shown in this case, or be confident to do a non-physiological renoportal anastomosis?
Thank you, Laura. I think we should try as much as possible to end up with a physiological shunt, because the problem is the portal hypertension. In this patient, if we cannot redirect the portal flow to the liver, the post-operative course is stormy, with ascites, with bleeding, the portal hypertension in a patient in early after liver transplantation. So we have to have a very good imaging and to try as much as possible to find a way to create a shunt to go to a physiological reconstruction. And if there is none, at that time, it's a discussion in the team if we go for a non-physiological reconstruction. It's on a case-by-case basis, and usually these are young patients that we want to transplant. And at that time, we have to prepare these patients because we know that they will have portal hypertension, severe portal hypertension, and increased portal hypertension worsened after the transplant. So we have to prepare them with a very intensive program of varices ligature before the operation. This is very important. Second, after the operation, there might be a place to some portal modulation. So I don't know yet what kind of pharmacological portal modulation we could use to decrease as much as possible the portal hypertension. But again, these are patients very young, that it's a team decision to go for a non-physiological reconstruction, and it must be prepared.
Okay, thank you. If I may ask another question. We have also some experience with anastomosis to the left gastric vein and pericholedocal veins. I have seen that in some cases, as you have no portal hypertension longer because you have not a cirrhosis liver, this chance squeeze, and we have some degrees of stenosis or inversion of the portal flow because of the. We have some experience to put afterward a stent to facilitate the flow. What's your opinion?
We have the same experience, but we try. Maybe it can help to ligate the shunt to ligate the varices after the shunt, downwards the shunt. So
Okay.
we do, for example,
Upward.
the anastomosis, and we ligate it to favor the flow to the liver. It's a very tricky operation because the angulation is not very favorable
Yeah.
to the liver.
I
So I
know.
think it's, but we have no choice.
Okay. Thank you much.
Merci, Laura.
Well,
Okay. Is there any question in the audience? I think there are no more questions. I have one question, Professor, as I'm a young sergeant. So after seeing your experience, do you have any contraindication of portal vein thrombosis in the
Yes.
liver transplant?
Victor, you tell me that you are a young surgeon, you mean that I am old.
No, 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 you're not old. You're experienced with a high
So
experience.
I think
You
there
have
is,
some.
I think, you know, it depends. It's really a team decision because I think there is no contraindication, none, to transplantation, provided there is a team consensus that you want to try and you take the risk to pay. The price is almost 20% of mortality in some cases with diffuse portal vein thrombosis, no shunt. If you do something non-physiological, I think the risk of mortality within 3 months is about 20%. So if you accept this risk, and it's a team decision, I think there is no limit.
Perfect. So we are on time. I don't know if anyone can ask anything. No?
Okay.
So we should conclude the session. It was a pleasure again to have you here.
Thank you.
Thank you for everyone to connect to the session. I hope you enjoy the rest of the Congress.
Thank you. Thank you, Victor.
Okay. Bye-bye. Have a nice day.
Bye. Have a nice day. Have a nice day.